Our last session of the day. I know everybody's pretty much scienced out, but hopefully you've learned a lot, and I'm really proud to present my next colleague speaker. Dr. India Sisler completed a fellowship in pediatric hematology oncology in 2009 and has since been the medical director of the Pediatric Comprehensive Sickle Cell Clinic at the Children's Hospital of Richmond here at VCU. She's a pediatric hematologist and she is dedicated to improving health care of sickle cell patients across the lifespan. Her pediatric program is comprised of a dedicated interdisciplinary professional team with interest and expertise in sickle cell care. She has a social worker, psychologist, educational consultant, in addition to medical clinicians. They have extensive experience in providing case management care for children and adolescents with sickle cell disease, and she works closely with Dr. Wally Smith and was an intricate part of our study that we had talked to you earlier about the SHIP-HU. She is an experience in utilizing community-based resources for sickle cell patients, and she serves as the site PI for the Children's Hospital Richmond's site of the Virginia Department of Health Newborn Screening Follow-Up Program, and she participates in the Virginia Pediatric Sickle Cell Consortium with the sites in Northern Virginia, University of Virginia, and CHKD. They have a robust clinical practice, and she provides comprehensive, high-quality care for approximately 300 pediatric sickle cell patients in Central Virginia. Dr. India Sisler.
Thank you. So I was tasked with talking to you guys about common complications of sickle cell disease right before we're done for the day. And right about the time that everybody's hitting that mid-afternoon slump. So please stop me, ask questions, raise your hands, ask specific questions about patients you've seen. Feel free to say, this is not something we see a lot, can we please move on? So I want this to be interactive, and I want you guys to learn a little bit about some of these common complications. So I like to think about this as not being redundant, but we're kind of hitting these common themes over and over again. So the damage is done in sickle cell in three basic ways, and if you can remember these three basic ways, you'll be able to understand all of the complications and why they happen. So the first is anemia, right? Anemia is just a word that means you don't have as many red blood cells as you should. There are lots of different reasons for anemia. We'll go ahead and start with that one. So in me, I don't have sickle cell disease, I don't have sickle cell trait. A red blood cell, when my body makes it, it lives 120 days. So they work pretty hard. They circulate around for 120 days doing their job. In patients who have sickle cell disease, the lifespan of a red cell is about 2 to 5 days. So those cells are constantly breaking down, constantly turning over. So you might have issues related to the fact that you don't have as many red blood cells, right? And you can also have complications related to the actual process of those red cells breaking down. We'll talk a little bit about that. Dr. Lopato hit on this and did a great job of kind of explaining how sickle cell disease impacts the plumbing. So this is just a physical problem. When you have cells that are sickled, you have impaired blood flow. So as you can imagine, anything that's sitting down here can be infected, right? Every part of your body, head to toe, and everything in between requires oxygen and requires blood flow. So every part of your body from head to toe can be impacted by sickle cell disease, and that's really the take-home message. So imagine any organ, skin, bone, muscle, at the end of that last cartoon there, whatever that is downstream is not getting the oxygen that it needs to properly function. And then Dr. Lopato also hit on this, kind of the inflammation, the endothelial damage that happens. So sickle cell, we used to just think of it as just a red cell problem. This is just a problem with the red cells, and that's very simplified. We now understand that it's really a problem with all of the blood vessels around the body because those are damaged over time. We've also gone a little bit through these different types of sickle cell disease. So you guys are experts now, right? You can talk to us about which are the most severe types and the less severe types. And we've also qualified that by saying that every patient is an individual, and sometimes the patients with the less severe types still can have very serious complications. So everybody needs to be looked at as a one individual patient. So this is exactly what I'm talking about here. Every organ, head to toe. We've talked a little bit about eyes already. We've talked a lot about bones. We've talked about stroke. We have not talked about a lot of these, though. So every part of your body can be impacted. And sometimes it's nice to think about these as chronic complications and acute complications. Chronic meaning that it's something that is prolonged over time, acute meaning that it happens suddenly. So there are lots of different ways that you can categorize all of these different complications. The one in blue, light blue here, are the ones that we're going to just briefly talk about today. We're certainly not going to cover an exhaustive list of everything that can happen in sickle cell disease. But if you have any questions, particularly related to some of the ones that we're not going to cover today, find one of us and we're happy to talk through it with you. Also, I think in talking about common complications, it's a good idea to talk about triggers. Do you guys hear your patients use the word trigger? It's something we hear a lot from our patients, and most of our kids, so I treat kids primarily, and so by the time my kids are kindergarten, first grade, they can talk to me about what their triggers are. Some patients are better than others at identifying their triggers, and some patients are better than others at avoiding their triggers. But essentially, you think about it as anything that puts stress on your body can trigger the complications of sickle cell disease. So if you're not getting enough sleep, if you are in extreme temperatures, if you are under physical or emotional stress, we talked a little bit about jaundice. We have a patient who told me this great story about how he did something that morning. This kid was 9, 10, did something that morning, was totally fine, totally his normal state of health. And his mother said, "You wait until your father gets home, okay? You just wait." So from that 10 a.m. until 5 p.m. when he was waiting for his father to get home, his jaundice, his eyes, his mother, she took a before and after picture because she had taken a picture for something that day, and then she took a picture at 5 p.m. when Dad got home. And the difference in the color of his eyes from that emotional stress where he'd been stewing all day long about wait until your father gets home. So this is a real phenomenon, and when patients when patients talk to us about things that cause them stress, it's really important for us as providers not to kind of minimize that going through any sort of life change really can impact the physiology of sickle cell disease. And I thought that was just such an awesome story and really brought that point home for me. Because sometimes I would have patients say, "Well, I was doing this, or this," and I'll be like, "Yeah, but still, well, I learned my yeah, but lesson." It's important to know that the complications are progressive. So I have the advantage of taking care of babies who are fresh and new and really have not experienced a lot of complications with sickle cell disease, but it's progressive over the lifespan. And some of the things that I'll say, Dr. Smith and Dr. Lopato can jump in, because the disease really does change over time as patients age. The way that they experience pain changes as they age. And the end organ damage is progressive over time. So there are a lot of things that Dr. Smith and Dr. Lopato see that I do not. There's some complications that are pretty unique to pediatrics that they don't see. But it's important for us to kind of understand that full lifespan of complications. And I would be remiss if I didn't also continue to call attention to the fact that mortality for our kids has decreased as care has improved nationwide, but mortality for adults has not really changed over time. And I think a lot of that speaks to what Dr. Smith had already shared with you this morning about the lack of providers and healthcare options for adults with sickle cell disease and why it's so important that we're all here today. Mm-hmm.
So for the life expectancy, so for the population that we see at Hopkins, it looks like the life expectancy is more. Is it because of the care?
It's probably that you have a pretty self-selected population, right? Okay. So those are patients who are in care at a tertiary medical center with sickle cell center, right? So that does skew it a little bit. Okay. This data is actually it looks like the life expectancy for both men and women is a couple of years shorter. The last time it was measured, if you compare from the early 2000s to I think 2012-13 is the last data we have available, it actually looks a little bit like the life expectancy is 2 to 5 years shorter. Why that is still a really big question that we don't understand, but I think it's a problem we all need to address.
rate in adults has increased because they didn't expect them or expect children to live so long. Or because sickle cell was always looked at as a childhood disease.
Right.
So now that they're living into their adult stages, it is this big increase. They're not like equipped to handle all
Yeah.
of these adult diseases.
And we're going to talk a little bit about that tomorrow in our transition talk. But you're right. Like as recently as the 1970s, the average life expectancy was 14 years when I was born. So when you think about it in that if we frame it that way, you think, okay, well, we've come a long way. So I don't want to dismiss the progress that we've made, but I do want to say that we've got a long way to go.
Some of that we call dignity over disease, and that's where they're choosing not to go to seek medical attention because of the medical bias that exists. Or
I like that term,
or
dignity
they are
over
being-
disease.
Or they are being undertreated or mistreated when they do show up.
I like that term a lot. Thank you. Yes.
So for the finding, for the children, is it 18 and under the ages, or was there a certain age?
Well, so that's an interesting debate in sickle cell care is like, when are you an adult? Yeah, so 22 here. I know my colleagues at CHKD, you guys transition around 21. We do high school graduation because it's kind of a functional mark, because I think all of us know 18-year-olds who have no business being an adult, and then we also know 18-year-olds who are very capable of managing their care. So we used high school graduation as kind of a functional, and then we play with that a little bit if we feel like we need to. But there's a lot of debate over when patients with chronic illness, and then sickle cell patients specifically, are ready to assume their responsibility for their care. So I don't have a good answer. Lots of questions. All right, so I wanted to start a little bit with pain. I'm not going to go into pain in detail because there's a session tomorrow to talk about this, but I did want to make a couple of points. So the reason patients hurt is because their bones and their muscles aren't getting the oxygen that they need. Okay, so you see all your bones have a blood supply, your musculature has a blood supply, and so when your bones and muscles aren't adequately perfused, then that causes pain. So that's kind of the underlying issue. And Dr. Smith alluded to this, but yes. Explain that, huh? That's an awesome point, okay? And so it's a local deficit of oxygen. So the patient has oxygen everywhere else that they need it, but for whatever reason, right here in these tiny little blood vessels of the knee, those cells have sickled and they've blocked blood flow right here. So everywhere else is still fine. Your brain's still getting oxygen, your heart's still getting oxygen, your other bones are getting oxygen. It's just right there that's local. So when we measure your oxygen saturation, that's kind of an overall measurement of what's going on in your body. And that's why there were studies done to see if adding oxygen on for patients will decrease the pain. So a lot of places still, when a patient has pain, the first thing they do is slap oxygen on. It doesn't really help because they don't have an overall lack of oxygen in their body. It's just really local to the bones and muscles. Did I answer your question? Okay, you're welcome. So Dr. Smith alluded to this, not all pain is crisis. And how do we define a crisis? And how do we define pain? I think it's really important to talk about with patients because they will tell you. If you ask a patient, is this your typical sickle cell crisis? Is this your typical pain? They can tell you yes, no. And I think it's important to listen to people when they say this is different. This is different than my usual pain. The crisis is kind of the term we use for an acute episode of pain. This is not chronic pain. This is, I'm doing fine today, but tomorrow I have this horrible pain. That's how most patients use the word crisis, but not everybody does. So sometimes I'll even ask patients, define a crisis for me. What does that look like for you? How many days do you usually hurt? Where do you usually hurt? What does that feel like? Because for some patients who are having really frequent pain, it helps me to try to understand the terminology that they're using when we're talking to them about their pain. It helps them own it a little bit too if you reflect back the terminology that they use. That's what I have found with patients. But there are lots of other things that can cause pain. So many other things that can cause pain. And one of the things that we're just learning about is really the chronic pain in sickle cell. So the patients that I treat when they're 7, 8 years old, in between their acute crises, they don't have any pain. If you ask them to rate their pain on a random Tuesday, it's 0. No, I'm not hurting anywhere. But most of the adults who Dr. Smith cares for, even in between their crises, they have some pain. So most adult patients have some pain every day. And I think that's the really important thing to try to understand as you're talking to each individual patient. Their profile of pain is going to look different. It's not going to be like I've treated twins who the way they talk about pain is completely different. The way they experience pain is completely different. They are completely identical. But I just really want to drive home that I think it's so important to talk to patients in their language about the pain that they experience. This is some work that Dr. Smith did looking at location of pain. You can see the entire body, the jaw, the clavicle. I had a patient the other day who told me he was having a crisis in his finger, this finger. So it can be very localized. It can be very diffuse. The other thing that I usually find with patients is when I say, tell me where it hurts, they go, here. You know, so it's a deep, bony, aching kind of a pain that patients describe when it's a crisis, and they generally will kind of give you an area. It's like, it's here, or it's here. It's very hard for patients most of the time to say, right here. This is some old work, 1991, but I think that it still holds up, that you see some patients with, this is the number of pain crises you have a year, so patients with SS have more pain. These are the patients that have 6 or more crises a year. But look at SC. Some of those patients are having really frequent pain. Look at S beta plus. Some of those patients are having really frequent pain. And the number of times one of my patients has told me, I went to the emergency room and they said, I shouldn't have pain like this because I'm SC or I'm S beta plus. I mean, that's some of that dignity over disease. That's some of the stigmatization that patients with SC and S beta plus, I think really that's hard for them to hear. It minimizes their disease and their experience. It's the most common reason for emergency room visits and admissions. There were 197,000 emergency room visits last year in the U.S., and it cost our healthcare system $356 million.
Is that just for sickle cell?
Mm-hmm. Mm-hmm. And so that's why your administrators, your hospital administrators care about sickle cell pain, but we care about it because if you've had more than 3 painful episodes in a year, that's been linked with an increased risk of death. So pain is a marker of disease severity. This is something called dactylitis, which is one of those things that's unique to pediatric patients. Think of these fingers as like little water balloons. So the blood's flowing in, then it's sickling, and it's not flowing out. But that doesn't stop the blood in. So the fingers or toes get really swollen, really tender. Most of the time when I'm teaching parents about this, and Jennifer they go, well, they already have pudgy fingers. You know, how am I going to know? But they will know. So I always reassure parents, you will know. This is different. You will know. You've experienced this?
My daughter, she was 9 months, and she wouldn't stop crying. Yeah. And it was a different, because I asked the same thing, how will I know?
Mm-hmm.
It's not a hungry cry, it's not a wet panther cry, and her leg was swollen, turning like flu. That was her first pain crisis, so you definitely know.
And this is another reason you're not just the parents, right? Like, you know.
I had an infant that wasn't crying, not like, it didn't seem like he was anything at all, but he couldn't grip and put your finger in his hand. Yeah. His finger, his pointer finger and his thumb wouldn't close.
Perfect, yes. We talked a little bit about avascular necrosis. We were talking more, it's more common in patients with SC disease where they have this bone disease. It's basically that a part of the bone dies off because chronically it doesn't have enough blood flow. This is a picture to help you visualize it, so I hope you won't forget it. So this is the knee. The bone's above the knee, bone's below the knee. This is a normal looking bone down here. And you can see here, this should be normal looking bone. This should be normal looking bone. But that's where that part of the bone has died off over time. And so you can imagine that that's not very stable, right? That bone, just looking at it, you get a sense that that's weakened and that it's not going to support that joint for long. So this is a patient that went on to have a knee replacement because of the instability in their joint. And that was a patient who could say to me, it hurts right here. So that was a very different type of pain. He was very clear that it was a different type of pain, and he could describe it as different to me if I took the time to listen to him, and then we got this imaging. It's an MRI. That's a good one, right? All right. So also wanted to mention that the average length of pain is 4.5. The average length of the pain crisis is usually 10 days. If you look at all comers, that's the average length. So this is not something that gets better in a day or two. Average length of stay in the hospital for pain crisis overall is 4.5 days.
I have a question.
Mm-hmm.
Is it ever going to stay that long? At our facility, our providers aren't necessarily ones who are patients. And what we find a lot of times is that the people who do admit don't know how to manage the pain, so the patients are there for a longer period of time. Is that length of stay related to that lack of ability and knowledge of the physician as to how to get the right input or the right amount to the patient? Or is it just that it takes that long longer to get the control?
I think it's probably both. So the question was about inpatient care and if the length of stay is longer because a lot of times patients aren't admitted to the providers who care for them in clinic. And so if they have a provider who's not necessarily comfortable with inpatient sickle cell pain control, and that sometimes prolongs their hospitalization, I think probably this is how long it takes. But I will say that there's a lot of evidence that if there is standardized inpatient care and standardized pain protocols, it decreases the length of stay for patients. So you cannot dispute that in sickle cell disease, and I think that's like here on our adult side. On our pediatric side, we admit to our own team, but on the adult side, they do not. And a lot of the work that Dr. Smith's team has been doing is around inpatient care and kind of standardizing pain control, and I think it's safe to say you've seen a real decrease in length of stay and a decrease in the burden to the hospital system overall.
We actually have
Mm-hmm.
where when somebody calls in with a crisis, we'll bring them in. And we don't use VCU at this time, but what we do is we give to a certain amount. We give them when their pain is controllable, they go home, they try to have their pain. If that doesn't work, they can call back the next day and come back in. And we can do that. By day 3, if we still haven't got them under control, then we'll call them an issue. Or of course, if there's something going on overnight.
Yeah.
We get usually get into it. So I guess my thinking was, if it takes that long, and we're only seeing patients sometimes for 1 visit during the week, and we're sending them home, are we truly treating sickle cell pain, or are we treating chronic pain, or what are we treating, and are we actually doing what we want to do to help the patients stay out of the hospital?
That's hard to tease out. I'd be interested to see how many of your patients do end up getting admitted despite day treatment, because I think that sometimes what we started doing on our inpatient service is 24 hours on a PCA, and then we convert you over to oral. Because for a lot of different reasons, but we want to decrease the length of hospital stay, and if we can get somebody's pain in a really good place and then convert them over to oral medications and get them home where they're moving, where they're not sedentary, where they're not going to catch some hospital-acquired infection, We feel like that's in their best interest. So we try to be a little bit more aggressive, like 24 to 48 hours on a PCA max. Right. Right. The longer you're on a PCA, the longer you're on a PCA. So I definitely think there is a role for what you're doing. I think it's just not going to work for everybody, but it's going to work for a lot of patients.
Yeah, I mean, I think we have increased some of our patients to those grade 3 frequency. I think we have built a rapport with them more and we limited timelines. So I think we built some monthly reports. Call one to us to go get a video.
Mm-hmm.
Just to say, I hate to sit in a meeting for 4 hours a night. And most times we can get them in or within an hour or two of the call.
That's awesome.
If we don't have, sometimes slow this down by the access, but usually we can take 30 minutes to get in the chair to get in and we do 10 minutes every 30 minutes. Like I said, we have a limit on what we can give you in a visit.
Yeah.
But I was just looking at that going, well, are we doing anything worthwhile?
No, I think you are.
Not getting them out of the.
No, I think you are. I think you are. If you're keeping patients out of the hospital, not to say that you're necessarily decreasing the length that they have pain, but you're keeping them out of the hospital, which is it has a huge impact on quality of life. I think it is the right thing. Mm-hmm. And this is why that is so important and why many patients tell us they hate to go to the emergency room, because the most clear data that we have about treating pain is that time is pain. And so if you can get somebody pain medication quickly, they're less likely to be admitted to the hospital. They're less likely to need longer term treatment. So some of the strongest recommendations we have are around how quickly patients need to have pain. Wanted to just briefly mention, we'll talk more about this tomorrow, but just to mention this concept of chronic pain, which is more frequent in adult patients than pediatric patients. Kind of the working definition is pain more than 15 days a month, which was taken from a description of chronic migraines. So it's not like the greatest definition, because sickle cell and migraines are not the same thing. But that's the definition that we have to work with right now. But we do know that chronic pain doesn't necessarily correlate with your typical markers of disease severity. And hydroxyurea is not great at treating chronic pain. It is great at preventing acute pain, but it's not great at treating chronic pain. And that we know that there's a really high somatic symptom burden. Patients are hospitalized more frequently for acute pain if you have chronic pain. So chronic pain really has a huge impact on quality of life. And this, every time I talk about pain, I have to talk a little bit about the stigmatization that happens with patients with sickle cell disease. There's a paper that was written, The Difficult Patient Conundrum, which is actually a really great paper. It's full of data as to why the difficult patient actually really isn't that difficult. But this is, I think, some of the best data. And these are patients who died due to overdose of opioids, okay? And if you look at the total number of opioid overdoses in the United States, I mean, of course you see the shocking increase over time, but the deaths in our sickle cell patients haven't really changed. There's no statistical increase in deaths by overdose. And sickle cell disease is the least likely population to die by overdose when compared to every other chronic pain syndrome. So, yes, you all get my point. I could stay on my soapbox for a long time about that, but I won't. You get my point. And one of the other things that patients complain about a lot, and they are justified in doing it, is that they go into the emergency room. You guys have all heard this story. I went to the emergency room. I told them I needed 4 milligrams of Dilaudid. They said, oh yeah, that's a red flag. You're looking for drugs. You can have 1 milligram of morphine. And I said, that's not going to treat my pain. And they said, I'm the doctor. You're the patient. We're going to start with 1 milligram of morphine. Well, the reason patients know what they need is because they've lived it. And we as a healthcare community should be listening to them. And there is data to show that patients with sickle cell disease require higher doses of opioids than people without sickle cell disease. They metabolize the drugs differently. It is a scientific fact that these patients need higher doses, they need it more frequently, even if they've never had opioids at all. So there was a really great study done where somebody smart was thinking about this, and they looked back and they said, okay, everybody that we've ever taken a gallbladder out on, let's look at how much opioid patients with sickle cell needed after they had their gallbladder taken out. And then let's look at patients, and these were opioid naive patients, so these were not people who were on opioids at home. These were patients who really hadn't ever gotten opioids before. The first time they got them was because they had their gallbladder out. Then they took a group of patients without sickle cell disease and looked at them. The patients with sickle cell required a lot more pain medication after they had their gallbladder out. So then somebody smart started thinking, well, why is that? And they designed this great clinical trial. And this could be my plug for why it's important for patients to participate in clinical trials, because we would never know this if somebody wasn't willing to participate in this trial. They took patients with sickle cell disease and people without sickle cell disease. They gave everybody a dose of morphine, and then they measured the metabolites. How quickly did they excrete it? How high did the drug levels get in their blood? And nobody wants to know any of these numbers, but I'll just tell you, the results show that in patients with sickle cell disease, they needed almost twice the dose as patients without sickle cell disease to get to the same drug level, and they excreted it almost twice as fast. There are lots of reasons for that, but just to say that when a patient says, I need 4 milligrams of morphine and then I need another one 30 minutes later, they really do. This is not, there's really great science to back that up. All right, that's my pain spiel. Anybody have any questions about that? I get really defensive of my kids who don't get their pain treated well.
So I'm not sure if every state or every medical facility has we have Epic.
Mm-hmm. Yeah.
Right? So they can see if a patient comes in and says, this is what I usually get, and would a provider check and verify so that, because of the stigma, so you won't,
Yeah.
use that to a patient?
So we have Cerner, so there's some great studies that have been published. We published one here a couple of years ago where we actually created individualized pain plans for our patients that the emergency room could pull up when patients came in so that they could see. And we decreased the length of stay in the hospital. We decreased the amount of opioid that patients get. So there's a lot of data out there that shows that if you look at what was done before and actually worked for the patient, that you're going to have better outcomes. And that's common sense to us. But the problem ends up being when they go elsewhere. So, we serve a huge catchment area. A lot of our patients drive from 2 hours away. It's the middle of the night. They can't get a ride. They end up in a local, for whatever reason, end up in a local emergency room. And that's when I hear most of the complaints. Although I will say many years ago, even in our own emergency room, I witnessed a situation that I was not very nice to the administrators in the emergency room when I witnessed this particular situation, which was a patient was really demeaned in a way that they shouldn't have been. So it still happens, but you're exactly right. I mean, and that's why we tell patients, it really is, I want you to come here because it's easier for me, because I can see what happened, but I also want you to come here because it's going to be easier for you. I have more control over what happens in the emergency room here. I got no control over what happens down the road.
I had some type of with sickle cell disease, my goal thing is that if we could get together and have a PSA. I saw an old PSA where a patient was in the emergency room. He was spraying. I'm like, whew, it was 1982. If we had something to put together, just to show what our patients go through and make it a PSA for maybe Sickle Cell Awareness Month or World, just to show, to give it a face, or maybe we can work together or think for something.
I like it. Yeah. We did a talk for emergency room, statewide emergency medicine conference. So it was EMTs, emergency room doctors, and we presented a lot of this same data about pain. And then I have a psychologist that I was working with at the time who presented a little bit about the psychology of pain. Right. And then we had a family that they could ask questions of and could tell their story. And one of the EMTs came up to me afterwards, literally in tears, and she was like, I'm going to go knock on this woman's door and apologize to her about the way I've treated her. So I don't think most of the time it's a lack of wanting to treat people right. I just think it's a lack of knowledge. Yeah. It would be helpful. I have no idea how you.
I was a Hopkins, and I had a nurse practitioner. Like, my doctor gave me like a card that stated like how I'm supposed to be treated, inpatient, outpatient, and ED, and it had all of my cards like baseline. He was over like all of my numbers on there, and then she told me straight to my face, I don't feel comfortable getting you
At Hopkins?
at Hopkins, and I was doing your convention.
Last year?
Couple years ago.
You guys need to talk.
I was just gonna make a comment. You gotta realize too, though, like Dr. Sister said, she's dealing with pediatrics. So pediatrics, like we all have all said, is covered, is great. But there's that gap that, like you all said, the transition, and then you have an adult who has been getting treated probably at Hopkins, excellent. And I know, but at the same time, you still have that gap. So it's like, once you graduate and become an adult, you get out there and it's like, yeah, no, we're not gonna listen to you, we're not gonna do what we're supposed to do. So that's where we are. And I'm just gonna say, I think the key, and everybody is right, the key is to get the politicians involved so that we all can come together and it will be one universal message that's sent out collectively across the state.
To her question about emergency department protocol, there should be one established. And the first thing on it should be wait time to be in triage and receiving that first dosage of pain medication. Because right now, the city where I live in, and there's several different hospitals you can go to. The wait time, first of all, patients don't want to go to the emergency room. So if they're there, it's like they last or something happening. So they already in a state of pain that's already unmanageable for them. And they get to the emergency room and have to sit and wait. And then you only want to give them 0.5 milligrams of your life, nothing. It's not going to ease or relieve the pain. There should be a protocol, not just a recommended guideline, but a definite standard of medication, wait time, and all of those things needed to get that patient quickly out of that current situation that you're in.
Yeah.
And so I don't know who needs to be addressed to get something like that going, but it's so necessary.
I agree. All right, I'm told by the time police up here that I have to keep going, so we'll table. No, it's important discussion. It's important. We'll talk more pain tomorrow. Okay, pulmonary complications. These are diseases of the lung. You can have acute episodes of problems with your lung. You can also have chronic damage that happens over time. So more common in adults than in children. Important to note that people with sickle cell disease are more likely than the general population to be diagnosed with asthma. So a lot of patients should have a pulmonary doctor that they see regularly to look at their lung function, to follow it over time, to see how it's changing. We work really closely with one particular pulmonologist here. And you can see 7 to 10% of kids in the U.S. have asthma, and up to about 50% of kids with sickle cell disease have been diagnosed with asthma. So there's certainly a component of that. And people who have sickle cell disease and asthma have more pain, have more acute chest, and are more at risk for early death. So making sure, I feel like so many people have asthma that a lot of times we underappreciate how severe it can be and how much it can impact your overall health. But it's even more important in patients with sickle cell disease to have really tight control of their asthma. So you tell patients, now you have another chronic illness that I want you to see another doctor for, and I want you to keep really good control of that too. You can understand how that's frustrating for our patients. And to talk a little bit about acute chest syndrome, have you guys heard this term before? Acute chest. Acute chest is really a clinical diagnosis, so it's the number one cause of death in children. It's the second most common acute complication after pain that ends up having kids in the hospital, and it's really kind of a clinical picture. So there's not a test that you can do to say, okay, you tested positive for acute chest, but it's more a constellation of things. So it's a chest x-ray that has some changes on it that look concerning. The oxygen is low on the pulse ox on the finger, so you are seeing low oxygen. Maybe fever, cough, chest pain, your heart rate's fast, you're breathing fast. So it's a whole clinical picture put together when we diagnose patients with acute chest. About half of all of our children have had acute chest by the time that they're 10. And we know that kids who have had acute chest have a shorter life expectancy than those who have not. So we've put a lot of emphasis lately on preventing acute chest in hospitalized patient, which is a whole nother talk that I could do for you. But basically what happens is, remember the picture I showed you of the knee where you have those blood vessels that are feeding the bones? Same thing in the chest. So you have those blood vessels that are feeding parts of a lung, okay? So the cells sickle there. You're not getting good blood flow. You have more hypoxia or less oxygen. Less oxygen actually makes your blood sickle more. So then you sickle more, you have less oxygen flow. So particularly in the lungs, this kind of cycle that can happen, this loop that you can get caught in if you don't treat it, is the cause for acute chest. I'll skip through some of this just because, but the most important thing I think to know about acute chest is that sometimes it happens in patients, like they come into the hospital, they come into the emergency room and they have acute chest. You can see it right from the first second you lay eyes on them. You're worried about it. A lot of patients develop it while they're in the hospital, about 70% of patients. So they come in for something else and then they develop acute chest while they're there. So this is something we work with our inpatient colleagues really closely to make sure that they're mindful of and they're looking for, and it's on their radar as a potential complication that can happen after hospitalization. Like a lot of things in sickle cell, there are 0 randomized controlled trials, which is our gold standard for how we develop treatments for anything that we do for acute chest. But what we do anyway is we use transfusion, like Dr. Lopato talked about. We use antibiotics if there are changes on the chest x-ray that look like it could be a pneumonia that's kicked off that process. Sometimes we use albuterol, sometimes we don't. So I'll skip over this too. But just, we also counsel patients that once they've had an episode of acute chest, they're likely to have a second. So we really try very hard to have patients understand what they can do to help prevent as far as good pulmonary care. The more you have acute chest, the more likely you are to develop chronic lung changes as an adult. So not only is it dangerous in the short term when it happens, but it's dangerous in the long term in the form of pulmonary hypertension or pulmonary fibrosis, where your lungs can actually become fibrotic because you've had so much damage over time. Any questions about pulmonary? That was a very whirlwind overview. Stroke. So this is the #1 cause of stroke in kids, sickle cell disease is. You're 300 times more likely to have a stroke than another child. And granted, stroke is rare in the pediatric population as a whole, but that's also a barrier because you're not really thinking about stroke in a kid a lot of times, and a lot of healthcare providers aren't thinking about stroke in a kid. So we need to have a really high index of suspicion. The other thing that happens is that a lot of times patients will have what we call silent strokes, so they'll never have the symptoms. You know, you have seen the PSAs on this, right, on stroke prevention. You guys seen with the facial droop and the slurred speech, and it tells you the warning signs to look out for. But sometimes patients don't have that. They have no symptoms at all, and then we'll get an MRI for some other reason and see that they've had a stroke in the past. About 17% of our patients, almost 20% of kids, have had one by the time they turn 18 without any symptoms. The risk goes up at age 2, so it's really young. We have kids that are 2 and 3 years old who have had a stroke. There are 2 types of strokes. So the hemorrhagic is when you actually have a bleed into the brain that causes the stroke, and the ischemic is without a bleed, where you just don't have enough blood flow. They happen at different ages. just so it's not really important for us to understand, why, but just to say that that does change over time, kind of that overarching theme that something about this disease changes over time from childhood into adulthood. And even though you can have a stroke at any age, it's a little bit different how it happens in childhood versus adulthood. So again, they can present dramatically or they can be silent. The risk factors are a previous TIA or a transient ischemic attack. Have you guys heard this term? It's basically, some people call it a mini stroke. It's stroke-like symptoms that resolve on their own. So if you've had that happen before, you're more likely to have a stroke. If you've had frequent acute chest syndrome, if you've had acute chest in the last 2 weeks, so again, that acute chest is important. If you're hypertensive, or if you've had an abnormal transcranial Doppler or TCD. So this is an ultrasound. This picture is so old, but it's literally like, but it's the same. You can't find another picture of a child getting a transcranial Doppler, so you've probably all seen this before. But it's basically an ultrasound to look at blood flow to the brain. So how well is she's happy, so it's okay. How well is the brain being perfused with blood? How well is the blood flowing? And it's actually a really great study to predict stroke risk. So we start doing these at age 2. Every 2-year-old gets one. They really like holding still for that study, I'll tell you that. It gets a little bit easier every year. And then we stop doing them usually around like 16 or so because the skull actually gets thick enough that you can't see well. So that's mostly the reason why we stop doing them at that age, is because you can't really see. So these are the kids. If the line is straight across, that means you haven't had a stroke. These are the kids who had an abnormal TCD. So if you have an abnormal TCD, about 30% of those kids will have a stroke in the next couple of years. If you have a normal TCD, it's very, very uncommon for you to have a stroke. So a normal TCD is very reassuring when we're looking at these patients. An abnormal TCD is something that we worry about and we act on. There is no way in adult patients that I know of for you to predict stroke risk. Is that true, Dr. Smith?
I'm not aware of a test that we can do like the TCD. The way I think about it, though, is by the time you're an adult, you've already had something happen to your brain in the way of silent ischemia. And so we know that adults have had something. And that's not predicting, that's just stating. And the adults need to know that. You just need to know somewhere in your brain there's been a little bitty stroke.
Yeah. So we do exchange transfusions that Dr. Lopato talked about for stroke acutely. It's important to know that you treat stroke and sickle cell differently than you do in the general population. So that's something that we work with our emergency department closely about, and yet another reason why we ask people to come to the specialty centers that know them. We talked a little bit about prevention of recurrent stroke. When Dr. Lopato was talking about hydroxyurea, he mentioned his patient who'd had a stroke before that he had put on hydroxyurea to try to prevent the second stroke. We did that study in kids. It's not been done in adults. And what we learned was that hydroxyurea was not great at preventing second stroke. It's better than nothing. But the best way to prevent a second stroke is with chronic transfusions. So patients come in and get transfused every month in our clinic to try to prevent. Now, if you've had just an abnormal transcranial Doppler, hydroxyurea does work to prevent stroke. We used to transfuse all of those patients too, but now we really just transfuse patients who have already had one stroke.
Is it transfusion or exchange?
We start with regular simple transfusions. When you move to exchange is who knows the right answer. All right. I wanted to talk a little bit about education because I think that this is a huge, for my patient population, this is probably the biggest impact on quality of life is how sickle cell impacts patients' education. And talk a little bit about how cognitive deficits and absenteeism can really have a high academic impact. Oh, okay. We doing? Yeah. put this earlier. In your experience with patients, how long must they wait in the ED before their first dose of opioids?
Oh.
Must they? Not should they. Must they?
Yeah, what's actually happening?
What's
Doesn't matter.
Well, that's reassuring. The majority of patients are being seen in under 60 minutes. No, about half the patients are being seen in under 60 minutes, which is the recommendation. The recommendation is that they're seen and get their first dose within 60 minutes. So, but you all could have told me we're not hitting the mark there, right? So just go here.
We didn't divide it up by children.
I guess I have to find this line again.
All right. So let me just ask a few words about cognitive deficit and stroke. The cooperative study on sickle cell disease looked at 350 patients over time at multiple sites in the 80s and 90s, and they did MRIs and neuropsychometric measurements on patients, and they found that patients who had had an avert stroke, the average full-scale IQ score was 70, with verbal IQ and performance IQ equally diminished, and that patients who had had silent strokes had poor performance on vocabulary, visual, motor speed, and coordination. So whether you had had an avert stroke or a silent stroke, there was an impact on cognitive function. And that seems to be a progressive decline. The verbal IQ scores, if you look at patients over time, decreases by about 0.5 point per year, with mathematics scores being specifically a little bit more heavily impacted. And this really starts early. There have been some studies where patients were tested starting at age 3, and there was an impact between ages 3 and 6 that you could already start to see on cognitive function. Wanted to mention that children with SS disease have an average of 30 days missed of school per year. So when you think about school's 9 months, so then you kind of translate this into the adult world. Do you know of a job where you're going to be able to miss 45 days of work per year and maintain your employment? So I think children with SC miss an average of 20 days per year. It's much greater than their siblings, so they controlled in this particular survey to make sure that we weren't just capturing families who allowed a higher rate of absenteeism. It was significantly higher than siblings. And there was a clear association between the days missed and academic achievement skills, as you would expect. So I think we need to be really careful and mindful when we want to set our patients up for success. We don't want them to be missing 30 days of school, but we also have to think about realistically what the workforce in the U.S. looks like and how patients can be supported to have successful career paths moving forward.
So my children, when they started high school, they actually started in home quarters because of their sickle cell. So just we talked before about the stresses of life, so the stress of being in high school. They went from this is not really good to school, so I think the entire part of school. The other thing too is in terms of like having accommodations for your child with sickle cell disease. What is, like, are there any guidelines or anything that's standard across your mind? Because I had a really, really hard time just getting a 504 plan for my children. I tried first the IEP, and they were like, well, I'm sorry, your kids are doing well, they don't get in any trouble, they don't need one. And then my daughter went from doing advanced math one part of the year to doing on-level math another part of the year because she was struggling, but still doing relatively well. But because she misses school, and when you're in advanced math, they go by so quickly because a couple of days, you probably miss the whole unit, they pull her out. And I didn't know any better at the time, but I realized they shouldn't have done that because as she had an IEP or even a 504, that wouldn't have happened. So it wasn't until they took her out of advanced math and put her in on-level math that I was able to get her a 504 plan, and at that point I felt like I failed her. So like, what is there, how, moving forward, me being a patient parent advocate, moving forward, how can I help other parents
Yeah, I've got some
not
back
go
there.
through what I went through?
So I've got some folks back there who I think want to answer too. I have a lot of thoughts on this, but
So I'll speak up a little bit. So I am with our pediatric department. I'm in psychology, but prior to that, I was a school psychologist before I went back to clinical degree. So in the schools, my role has always been, and my push will always be to families is immediately, whether it's preschool or kindergarten, or you don't put your child in preschool, set up a meeting with the school counselor and the school principal and the teachers immediately. Your child should always minimally be given a 504 plan. The IEP comes, unfortunately, with the school system, it's a wait to fail model, as you guys are probably very familiar with. That doesn't mean that if you've got the 504, you can step up to an IEP eventually. The thing is, and I think I want to bring us back to the cognitive deficits, when we think about a child who the average IQ is anywhere between 85 and 115, with a standard deviation of 15. If you're talking about a child with an IQ of 70, they're significantly below where they should be, meaning they're going to need accommodations and remediation across all areas of daily functioning, and that is something that should be given immediately and should never be something that is not given to a family, a child, anyone in need. So my thing is always advocate, advocate, advocate. You have rights, and if the school is not giving you what you need, there are people in the community, there are advocates in the community. Those are the people you need to reach out to. There aren't, and for us at least, we have educational consultants who go to these meetings, who provide the educational testing if the schools won't do it. There are people in your communities. It might take a little bit to find them and connect with them, but that is what my thing always will be.
and I will. I'll say my experience. So I have a daughter who has a 504 plan. I feel like I'm a fairly intelligent person. I couldn't get it done. I could not get it done. I had to find an advocate that spoke the same language who was in the room with me. And so my advice, I would implore you as an advocate in the community, what I see as a physician is families who desperately want to do the right thing for their kid, but don't have the resources to do so. And plus they're trying to take care of a kid with a chronic illness. They're trying to live life like they're depending on their circumstances, the amount of time or energy that somebody can contribute to that process can sometimes be pretty limiting. So where we struggle is families who you give them okay, I need you to do A, B, and C by the next time you come back and see me. And then they come back and they go, oh, I was going to, but then I didn't because of this happened, or my brother got sick, or, so as a community, I think one of the biggest impacts you can have in pediatric sickle cell is if you as an advocate stick with a family and walk them and don't give up on them, and because you speak the language now, you know what the barriers are, you know the process, and that is hugely valuable. And when you're talking about quality of life and outcomes as far as people's vocational and educational success, if you don't do it now, then you lose your window.
So we just had our bill passed in Maryland, Senate Bill 161, which became law in July. So, so I testified on that bill, and it is now law. So,
I'm hoping that looks like really how.
yeah, I was gonna say.
I mean, we're out of that situation now.
Yeah.
My youngest was in she's a senior in high school. So.
Okay.
feel like we're not gonna accept that you're not going to provide this to you have to advocate, and I think you're also showing your child that they're worth advocating for. And I think that it's frustrating when you're in that role, and you're like, I'm trying to help my child, and I don't know what to do, and the school aren't listening, but we need to be able to see that you can do that for them, so they can learn how to do that for themselves. Because, we're identifying that that's an issue with the older and advocating, so they need that example.
Yeah. And I think as a community, as a sickle cell community, one thing that we really have to do is say, this is the skill set that I have as a parent. This is my strength that I have as a parent advocate. It may not be a strength that you have as a parent advocate, but I know you have another strength. So how do I walk alongside you for this walk that I have dealt with, and I've got expertise in educational issues? How do I walk alongside you for that? And and I'll be happy to have you walk alongside me for something else. A lot of it goes back to community building, which I think is so hugely important, and setting up opportunities where parents can learn from each other and advocate for each other, build community that way. I think I'm out of time, but y'all, let's just do comments then. I don't know what else I was even going to talk about, but this is important. But they will break you down until you finally just take no because you can't handle it anymore.
They really don't want to do it for you.
Most states have organizations like PACER or Parent to Parent, and you're talking PACER and Parent to Parent, particularly around families who have children with complex medical needs who have already had to jump through these hoops and have now learned from that and go back to the community to share what they've learned. And those are the people that can really take you further. Even the advocates, like, we can't be at every single meeting, we'll be at as many as we can, but when you meet parents and families who have already had to jump through these hoops, who, like yourself, learned too little too late, you now can then take your knowledge and put that back into the community for those who will come after.
Yeah, real quick, and I don't mean to be sexist on this, but you look at the population in the room, mostly women. A lot of times when I go in, they're going to tell me nothing, no for nothing.
Wow.
I'll tell you why. Because when I look at them, you are doing for me because you are employed to do that for me. I pay your taxes and all this other good stuff. So anything you tell me that's not what I want to hear is wrong.
Wow.
And whether I'm right or not, you're wrong.
But isn't that a fascinating perspective?
So we have my two boys, and they have the 504 plan. And every time I go in there, the person is improving upon what I started them with. It was, I was doing this, and I think maybe we should add this for him, do this and do that. And we also have a nephew we take care of. He has a VIP. Same thing. Every time we're going in there, we're doing a little bit more, pushing their staff a little bit more to get more resources. And Tiffany will tell you, I don't speak up on a lot of stuff. She's the butterfly. She floats around and does things. But when it comes to this, nah, you're going to talk to me, and it's going to be what we agree to, and there is no option.
I like it.
I would also take it a step further. As a woman and as a sickle cell health educator, when I go into a room, I don't say no for any reason. As a community-based organization, I think, North Carolina lays the trail with what we do. I send folks into the school systems, so I would encourage you to find that network of our support group or a community-based organization, or reach out to SCCAPE to find a CHW that's local, so that way we can go in and advocate for you. I mean, that's like a part of the triad that IFE's grant is working on, is like, it's peds, adults, and the CBO coming to the table. Why? Because we had an opportunity to go knock on doors, or go to your house, or go to your school system and be that advocate and that educator to, your educators, the nurses, the principals, whoever it is. So it's not just men that they listen to.
I'll preface my statement.
All right, one more comment, and then we got some more prizes.
I think that's a really good point. The big thing coming from my experience in the school system, there's not education based on what the needs of certain populations are, whether it's we're talking about sickle cell or any other chronic medical condition. The schools are only focused on education. They don't have the medical side, and so the more we can come into the school system and say, I'm not here to push and pull or anything. I'm here to just tell you. I'm here to provide the information to you. They will grasp at that. They will pull at that. They will ask you to come back. They will ask you to sit in on meetings that you weren't invited to with the family. They want you there. They just don't know that they want you there. They don't know what they don't know.
They don't know that they
So
don't
the more
know.
that we can stand up and say, here's what you know, here's what I can help you with, they're gonna, they need to come back.
They don't know.
They need us. They need us just as much as we need them.
Thank you, Dr. Sisler. I think we all agree that was very insightful. Appreciate it. I do have a couple of announcements. The evaluation, don't forget, is in your spiral notebook. And please just put your name on it, and you might want to go on and fill some of it out tonight while you can remember stuff. But if you leave early, any time that you leave, if some of you I think are only going to be here through tomorrow, please tear that out and turn it into the registration table, okay?
Can I just ditto that? Why is that important? That's important because if you want to do this again, we must have an evaluation of how well it went. Partial attendance, full attendance is part of that evaluation, and how well you thought of each section individually is part of that evaluation. So do it tonight. Do not wait.
Do not wait.
Do it tonight, and keep up with it so that at the end you don't just throw it away and say, I don't have time.
Right.
I'm not playing. Go back.
Right.
Do it now. This, just to be honest with you, this is not going to happen again unless we have
Right.
good information.
That's right. Thank you.
Names or everything.
Okay. Okay, also, you want to hear